name is Leanne Garrett, and I am the public health entomologist here at the lab. So I'm dealing with all of the mosquitoes that we get in, mostly for West Nile virus, but also now Zika is a concern. I have just a brief presentation that kind of goes over what the vectors are, and I apologize if you're already familiar with that, but for those of you who know more about the human side, this is more about the vectors. The Zika virus is transmitted by Aedes mosquitoes, and these ones also can transmit dengue, chikungunya, different viruses like that. They also have kind of an unusual behavior. These are daytime mosquitoes, whereas most of the mosquitoes that we're familiar with, we associate with dusk and dawn. But these ones are out during the day, so it's important to put on your bug spray, not only when you're out at the campfire at night, but also during the day. And then there are two species of Aedes that have been found in Ohio. We have found the Aedes aegypti and then Aedes albopictus. So comparing these two, Aedes aegypti is the one that's most commonly known as the yellow fever mosquito. And then the Aedes albopictus is what you may have referred to as the Asian tiger mosquito. That's the one that's it's really distinct, black and white, so that got the name tiger. Aegypti is the one that is the for sure confirmed vector of Zika virus, and albopictus right now is just a potential vector. It's been shown to transmit it in the lab. It hasn't been found to transmit it out in nature as much. So the aegypti is not established here in Ohio. So the confirmed vector is not established here. It has been found, but it does not survive. The albopictus mosquito, however, is established year-round. We collected a lot of them last year, but again, that's just the potential vector. So aegypti can be found outdoors and indoors. It's very closely associated with humans to breed and live right where humans are, whereas the albopictus stays mostly outdoors. And then aegypti will breed right in your backyard near your home, whereas the albopictus can go, will be comfortable out in the woods in more natural settings. So the mosquito that we do currently have here has a lot more good characteristics as far as keeping us safe from Zika, whereas this one is the more dangerous species. And then aegypti will target humans to feed on, whereas the albopictus will feed on a variety of animals, so it won't specifically seek out humans if there are other animals around to feed on. They're what's known as container breeders. So these mosquitoes will lay their eggs on the surface just above the water line of any kind of container of water. And then when it rains, when the water level rises and the eggs get wet, then that's when they'll hatch. And here you can see the larva growing. So these containers that they breed in can be either natural or man-made. Natural ones can include plants like this bromeliad. It's more of a tropical species, but some people may have ornamental plants that can hold water in their leaves here. Or also trees like this that have roots that come up above the ground here. They can form pockets that can hold water. Those are nice ideal places where the mosquitoes will breed. And then the man-made habitats include bird baths. This is a really nasty, dirty one that's been cleaned in a while, but anything in your backyard that hold water, flower pots, the little dishes underneath that drain the water. If you leave some water sitting in there, they'll breed in there. And then also scrap tires are the biggest place where we find a lot of these mosquitoes, and these get transported all over the country. So what we're using to try and capture these mosquitoes and do some surveillance is this new trap that we started using last year. It's called BG Sentinel Trap, and this one was designed specifically for the Aedes aegypti and Aedes albopictus. It has a scented lure it imitates like lactic acid and the different chemicals that are in human skin and sweat. So that is a specific formula for these that attracts these species, and it plugs right into the top of the trap here, and it'll attract the mosquitoes that we're looking for. So once we'll go around, we'll set these traps, and then we have to go through and identify all the species that we caught. So I'll just kind of go through the physical characteristics, how you can tell these two species apart. Both of them do have the white spots on their legs here at the joints, so they do kind of look similar. However, the Aedes aegypti has more brown scales. Mosquitoes actually have scales like butterflies on their wings and on their bodies. So this one is covered in, so this one is brown, and then whereas the tiger mosquito, the Asian tiger mosquito that we do have here in Ohio, is more of a distinct black and white. On the top of the mosquito right here, the aegypti has multiple lines here in this pattern, and then the Asian tiger mosquito, albopictus, has just one straight white line, and this can actually be seen just with the naked eye. You can look at it; it's pretty obvious. You don't need a microscope or anything like that. And then another small difference is these spots here along the abdomen. The aegypti mosquito has more circular-shaped white spots, whereas the tiger mosquito has more triangular spots. So this is a map of the past collections of Aedes aegypti. You can see the years. There have not been any captured or that we've found in recent years. And all of these have been associated with those tires that I mentioned earlier. So there's some tire facilities that either recycle them or retread them, and that's pretty much where all of the aegypti mosquitoes have been found, and it's all been later in the summer. So these mosquitoes were probably transported in the tires from somewhere further south where it's a more temperate climate, and then brought up to Ohio. But then they can't become established here because they're more sensitive to the cold, so they won't survive the winters. So, and that still remains the same. If we do find more aegypti here in Ohio, they'll still most likely be killed once the winter comes. But they can be transported up here during the summer. So comparing that to the albopictus, this is a map just of last year. All of the blue counties, the solid blue and the hash marks, that's where we had any type of surveillance conducted. And then the solid blue shows where we actually found Aedes albopictus. So you can see that even though this one is able to survive the winters, it's still pretty sensitive to the cold. So it's mostly in the southern half of Ohio here. We haven't found many up further north. So it's still temperature sensitive. So this year we have made a change to how we're doing the surveillance, going along with the CDC wanting more detailed information about the mosquito collections. We're attempting to standardize the procedure for all of the counties, which is a challenge, but it's working. Hopefully everybody can get on the same page, use the same form, report the same information. That way our database is complete and we have all the information that the CDC requires. Then with the standardized system, we can then also use it to check, look up past data and reference it. That way we have tons and tons of data, but right now from year to year the location names have changed and things like that, so it's hard to kind of put together a long-term picture without a lot of work and searching. So hopefully if this continues through the years using the standardized system, standardized names, then it'll be a lot easier to search. So again, we're just using the standardized system, and it'll be tied to a physical location, so you can just search for a single trap ID, and that refers to perhaps a park or something, and you can look at that not only through the summer, but then also through the years, hopefully if this continues, and that way we can allow for graduate student projects and research and all sorts of data analysis with this. So that's about all I have. Hopefully every county has received a notification about the start of mosquito surveillance season. We've started accepting samples. If you have any questions, if your environmental health director or whoever's in charge of your surveillance program has not received an email from me, then go ahead and send me an email, get in touch with me. I'm a little behind in responding to some messages, So I'm catching up with that quickly, and if you have any questions, just let me know, and I'm here to help.
Good morning. My name is Kevin Soner. I'm with the Ohio Department of Health Laboratory, and part of the laboratory section that I manage is responsible for testing for Zika virus. So I thought it's always instructive, at least for me, when you start talking about testing for things like Zika viruses, to take a look at what the host response looks like. Because we have a couple of tools in the arsenal. Some of them are nucleic acid amplification or PCR-based tests, and the other ones are serologic tests. So we can test for IgM. And essentially, when you have the host response in a typical, this one, I mean, it says Zika, but it's probably would be typical for any Zika virus infection. So if you look at the timeline down here, and this is 0, this would represent pretty much the onset of symptoms. And that's great if you have somebody who's symptomatic. We'll talk about that first. What happens is somewhere back here we have infection. And what happens is we have viral replication. That's what this viral RNA is letting us know. So eventually, the host will produce antibodies to this infection agent in a couple of different types. The first type that's going to appear is this sort of gold line here that represents IgM. That's a class of antibodies that's produced early on in an infectious process, followed by IgG, which is usually what's responsible for immunity and persists for a long period of time. Now recently, CDC has announced, because things are always changing, we're finding out more and more about the host response for Zika, and they're finding that in some cases, IgM is much more persistent, which is represented up here by this dotted line. So if we take a look at what we have in our arsenal, which is the PCR type test and the serologic test, if we were to test somebody around this point, and really what we're talking about is anything inside from 0 up to about 2 weeks, you can see that we would be able to probably detect viral RNA, so our PCR would be positive at that point. However, antibodies may not be present in sufficient quantities to be detected. So they might be negative, but we also might be able to detect them. You can see that in this area, we're starting to get, if this little line here represents the sensitivity of our test, at this point right here, we would be able to detect a little bit of IgM and possibly even some IgG, but it could be negative as well. If we were to test, if we didn't know, let's say, exactly when the date of onset was, we had an asymptomatic individual, we might conduct testing out at this point. And at that point, you can see that our PCR would be negative because our viral RNA has declined. The virus is no longer actively replicating. Our IgM may or may not be positive because if it were to drop off to this point over here, we wouldn't be able to detect it. However, if it were persistent, we would be able to detect it. The take-home message here is we wouldn't be able to tell whether that positive IgM would represent acute infection anymore. Typically it does. And I think that's the message or the subject of the health alert that CDC has recently released. And you can see that even further out, we may have, our PCR of course would be negative, our IgM may or may not be positive, and probably if we were testing for IgG, we would be able to detect that, but it wouldn't tell us anything about the acuteness of the infection. So then, this is going to be a few slides that represent the current testing algorithm that we use at the laboratory. This assumes that we have a patient that is symptomatic, and you can see that we would start out by testing all of these specimens by PCR. We would also test for other viruses that are endemic in areas where Zika virus transmission is ongoing. And we would also eventually use our serologic tests to determine, so the combination of both of those things gives us some idea of what's going on in potential infections. Now the good part about it is you don't need to know this really. We'll take care of the testing. All you need to do is get us the sample. The other thing that I should mention is PRNT testing down here. That's going to be necessary in cases where we don't detect viral replication, so no nucleic acid or RNA is detected. We do have evidence of serologic evidence of potential infection, but the serologic response can cross-react. There can be some cross-reactivity with other flaviviruses. So in order to figure that out, we would rely on what's known as plaque reduction neutralization testing. And that's a much more specific test that will allow us to be able to tell precisely which flavivirus we're dealing with. Again, this is kind of divided in less than 14 days or the acute phase of the infection, and then greater than 14 days, again assuming symptomology. Essentially the testing algorithm is relatively the same. Where differences may come in is when we're talking about asymptomatic pregnant women. So I'm just going to run through this. You probably maybe have this algorithm, or you have a copy of the CDC announcement. You can review that later. So I'm not going to get into a lot of detail about this, but essentially for asymptomatic pregnant women, and Kim Macheski may have more to say about this, you just have to be aware that there are some cases where additional testing may be in order. There's our little friend PRNT again. The right side of the screen represents our serology. The left side of the screen represents what we can do with PCR. And then this is just a summary of the guidance that was released by CDC. And again, I'm not going to read that. That's me. Again, I supervise the laboratory where the testing is done. If you need testing, you don't want to really call me. You want to call our outbreak response team. They will arrange to have, and they'll tell you exactly what to do to, get testing performed.
So I'm Kim Macheski. I'm an epidemiologist in the zoonotic disease program. So we kind of help coordinate laboratory testing. We spend a lot of our days talking to local health departments and healthcare providers on arranging testing or talking about eligibility, people who are eligible for testing. We follow CDC's criteria on that. We also talk a lot about recommendations too. We get questions all the time. How long do people need to wait before conceiving when they've been in an area at risk for Zika virus infection? So, I think at least once a day, every day, we're talking to healthcare providers and local health departments on these kind of topics. We also interface with the laboratory quite a bit on specimen tracking. So we all the specimens that arrive at our laboratory, we check all the paperwork that comes in and make sure we have all the pieces that we need to approve testing on certain people, again, following CDC's criteria for testing. So that would be symptomatic people who have a history of exposure, whether it be through travel or through sexual contact, or for pregnant women, if they're asymptomatic, we'll do a screening too. So, a lot of times this paperwork comes in and we need to chase down additional information on pregnancy status for females or travel with dates, because that timing, as Kevin showed you on that slide, we need to make sure we've got accurate dates for symptom onset or travel to know if we're within that 14 days to be able to run PCR or not. So, there's a lot of runaround there. We also facilitate reporting of positives or presumptive positives to local health departments. Whenever something comes up positive, we make sure that we get that entered into the Ohio Disease Reporting System, which is the electronic surveillance system that we use in Ohio for communicable diseases. We also follow up with a phone call to the local health department to make sure that they're aware of this person. We've encouraged healthcare providers to talk to their local health department when they're submitting specimens for testing, so that they're aware that somebody is being tested and could potentially come back positive. Sometimes that's the case, sometimes it's not. So we make sure that we call just to make sure, as soon as we know that's there could be a suspected case, that you guys know as well. Sometimes we get presumptive positive results from commercial laboratories as well, not just coming through ODH Lab, but there are many large reference labs that now do the testing. Early on, it was only public health laboratories that could do the IgM and PCR testing, but now that is available at several commercial laboratories. So some people are getting testing done there because I don't think that they follow CDC's algorithm. They'll just test anybody and can pay for it. That's one way we find out. Another, the Red Cross laboratories are screening all blood donations now for Zika. They've been doing this since November, using a nucleic acid screening test. We've had a couple donors that have screened reactive. This does not mean that they are necessarily a case. They have to follow up with confirmatory testing on that blood donor's sample, and that testing can take a couple weeks, but we make sure that we get an investigation started while we're waiting for confirmatory testing. And just a note, of only about 18% of donors who screen initial reactive end up being confirmed with Zika infection, so it's got a pretty high false positivity rate on that screen. Then we work with local health departments on the case investigation. So once we've got somebody that's a suspected case or even confirmed case, if we get that positive PCR and we already know that that they've had the Zika virus RNA in their blood, they're a confirmed case. So we work with local health departments on trying to get all the pieces of information that we need for the investigation. The laboratory is just one piece. Sometimes there needs to be additional confirmatory laboratory testing, but travel histories with dates and accurate countries of travel, pregnancy status for females, collecting information on mosquito and outdoor exposures. We look for non-vector-borne exposures, such as receiving a blood transfusion or an organ donation, sexual transmission. If it's an infant, whether there could be congenital or infection in utero possible. We also, they look at further transmission risks, such as while this person was infectious, could they potentially have infected a sexual partner, or if it's during mosquito season and they were infectious, were they using repellent? To avoid infecting any local mosquitoes here. And then local health departments are recommended to go out and do vector assessment in suspected cases' homes to look for any potential breeding sources, to look for any evidence of the potential vector that we had talked about, the Aedes albopictus, and right then and there they can just do some breeding source reduction or larviciding or adulticiding if warranted and able. So once a case meets the CDC standardized case definitions, we facilitate reporting to CDC. We also update numbers on our website. We have a Zika website. It's just odh.ohio.gov/Zika, where we keep all our case counts up to date. I think we had 95 cases last year in Ohio, all of them travel associated. One was through sexual contact with an infected traveler. And this year so far we've just had 3 travel associated cases. And then a last piece of this is connecting people to healthcare services if needed. There's clinical guidance for healthcare providers caring for women who are pregnant that have a possible Zika virus infection and making sure that they have all that information. And also there's guidance for pediatric healthcare providers that are caring for infants born to women with possible Zika virus infection. So we make sure that healthcare providers have that information, and then if a pregnant woman ends up testing positive for a possible Zika virus infection, she is enrolled in the U.S. Zika Pregnancy Registry. This is a national registry, and then there's further follow-up that occurs at that point. So I'll turn it over to Shelby Hale, who's another epidemiologist in the zoonotic disease program, and she coordinates a lot of the follow-up through the U.S. Zika Pregnancy Registry.
Hi everyone. I'm just going to talk briefly on what the U.S. Zika Pregnancy Registry is, who is eligible for the registry, and what the process is, as well as Ohio's role. So as many of you know, Zika virus is the first known mosquito-borne virus to cause birth defects in humans. An infection with Zika virus during pregnancy is a known cause of microcephaly and other severe fetal brain defects. Other problems that can come from an infection with Zika virus during pregnancy are miscarriages or stillbirths. And other problems that have been detected among fetuses and infants include absent or poorly developed brain structures, defects of the eye, and impaired growth. So because of this, CDC wants to better understand more about Zika virus infection and pregnancies. So they established the U.S. Zika Pregnancy Registry in March 2016, where they work in collaboration with state, tribal, local, and territorial health departments to collect information about pregnancy and infant outcomes following laboratory evidence of a Zika virus infection during pregnancy. This data is collected for the registry and is going to be used to update recommendations for clinical care, plan for services for pregnant women and families affected by Zika virus, and improve prevention of Zika virus infection during pregnancy. The U.S. Zika Pregnancy Registry is really an active surveillance system, which requires extensive follow-up with the pregnant woman as well as her healthcare provider to get as much information as possible about the pregnancy, the exposures, the birth, and any birth defects that may develop after the infant is born. So who is eligible for the U.S. Zika Pregnancy Registry? Pregnant women and infants diagnosed in the continental United States or U.S. territory, with the exception of Puerto Rico, they have their own pregnancy registry, with laboratory evidence of a recent Zika virus infection are eligible for tracking in the U.S. Zika Pregnancy Registry. And it is important to note that if an infant is born to a woman who has laboratory evidence of a Zika virus infection, doesn't test positive when it's born, we will still include that infant in the pregnancy registry because there is a follow-up that will continue for the 12 months of the baby's life. So what is the process of the U.S. Zika Pregnancy Registry and what does Ohio do? So the process starts with a pregnant woman with an exposure. This can either be travel to an area with Zika risk, having lived in an area with a Zika risk, or having sexual contact with a traveler or a resident of an area with Zika risk. The process starts with that pregnant woman being tested. The results are available within 1 to 2 weeks from ODH Laboratory. So we begin our follow-up for any pregnant woman with a presumptive positive findings for Zika virus or flavivirus infection. It takes CDC about 4 to 6 weeks to report their confirmatory testing, the PRNT testing that was mentioned earlier, on presumptive positive specimens. So ODH and local health departments begin interviewing the patient and speaking to the OB provider as soon as possible about starting the serial ultrasounds that are recommended and filling out the first form of the pregnancy registry known as the maternal health history form. Once CDC confirmatory test results are available, like I said, it takes about a month. And the pregnant woman meets the criteria for the registry, we will enroll her and report her to CDC. ODH and the local health department will then work together with the birthing hospital to prepare them to collect birth products and infant specimens when the baby is delivered. At the time of birth, the neonatologist or the pediatric healthcare provider at the hospital, we ask that they complete a neonate assessment form. This is the second form that we collect in the registry. And this is where they would collect information on the head circumference of the baby and any birth defects. They do, if imaging is done, they would collect this information there, and hearing screening, vision screening, all that information will be collected on these forms. And so this is very important. The specimens that must be collected at the time of birth, we ask for placental tissue and umbilical cord, and then specimens on the infant, a serum and urine specimen. But it's very important that we get those specimens within 2 days of birth so that we can distinguish between the infant actually being infected versus just a maternal infection. So we have a very small window that we have to work with the local health department, with the healthcare providers to collect those specimens in lab as well. Follow-up with the infant's pediatric healthcare provider occurs at 2, 6, and 12 months at their regularly scheduled well baby visits. Women with laboratory evidence of possible Zika virus infection who are enrolled in the registry are also eligible to receive home visiting services from ODH's Help Me Grow program. Those who accept the services can receive weekly visits, developmental screenings to help track the child's progress, and any help the families may need to in securing other services for developmental delays or other issues that may arise. So ODH works with local health departments throughout this entire process, and then, as Kim mentioned, it's a national database, so ODH facilitates that reporting. We work on collecting all of those forms, talking with healthcare providers, talking with the local health departments, collecting all that information on that baby, offering those services throughout the first year of life to the mother and the infant, and we report that up to CDC.
I'm Anna Starr, and I work in the Bureau of Maternal, Child, and Family Health in the Office of Health Improvement and Wellness. And I do want to take just a quick second and thank my colleagues in the administration and the Bureau of Health Preparedness and the Bureau of Infectious Diseases for including health improvement and wellness in part of the department's comprehensive Zika response. It's been a great collaboration. So specifically at ODH, I manage the unit that does birth defect surveillance. And as Shelby just mentioned, of course, birth defects such as microcephaly and central nervous system disorders and eye and ear disorders and brain reduction disorders are all a big concern related to Zika. So for a number of years, ODH has had a birth defect surveillance system, but it's been a passive reporting system where hospitals report the data to ODH, but it usually has a 1 to maybe even almost a 2-year lag time because you have until a year after a birth year is ended to actually report the case. So CDC offered Ohio to apply for some funding to ramp up our activities and do more rapid case ascertainment. So we employed a system where we need to find out about these potential birth defects much faster than reporting them a year later. So we have been using ODH nurses in the Children with Medical Handicaps program to go to hospitals, and they do very thorough medical records reviews, and they complete very detailed case abstractions on every suspected case of a baby born with one of these birth defects, regardless of whether there is any known Zika exposure. So they've been doing that since about October of last year. So they've abstracted 215 cases so far. 80 of those cases have actually been determined to meet CDC's case definition for that birth defect. However, 0 of the cases have been determined to be related to Zika exposure because, of course, there are many causes for microcephaly and some of these other birth defects. So our nurses will continue to do that probably through April of 2018, and then we'll see what our funding allows after that. But every baby who is identified as being a true case of one of these birth defects does get referred to the early intervention and the home visiting program in their county of residence so that the staff there can do some additional follow-up. There is a little bit of evidence out there that sometimes some developmental disabilities and maybe some other birth defects can occur later, even after the follow-up from the U.S. Zika Pregnancy Registry. So that's kind of, in a very quick nutshell, how our Zika-related birth defect surveillance system works. The other project I wanted to briefly mention is we collaborated with the staff in the Bureau of Infectious Diseases and wrote an activity in the expanded laboratory capacity grant about educating women's health clinicians about how to talk to and screen their patients about Zika and possible Zika exposure, where to send the women for testing, how to register them for the U.S. Zika Pregnancy Registry, how to work with the local health jurisdiction if they do have a patient that's on the Zika registry, and just all of the things around that, because some of the things that our nurses have heard when they're in the hospitals doing the case reviews is sometimes OBGYNs don't remember they should be asking their patient at every prenatal visit, or maybe didn't know exactly where to send people for testing or how to get connected with the Zika Pregnancy Registry. So ODH will be putting out a solicitation request probably in a month or so. We would like to contract out for this activity. So to do some kind of a continuing education activity that will offer CMEs for physicians and nurses and nurse midwives, and kind of promote this around the state and really get some targeted intervention to these providers. And I know I've gone really fast, and if anybody would have any questions for me, you're free to email me at ODH, which is anna.starr, STARR, at odh.ohio.gov, or you can call me directly, 614-995-5333.
I'm Allison Murphy. I am the Nutrition and Administrative Services Manager for the Ohio WIC program. WIC is in all 88 counties, but not all 88 counties have the actual administration of the WIC program for their county. WIC is in 56 health departments. The other 19 are within other private nonprofit agencies, be it community action, hospitals, or FQHCs. So WIC's role in all of this is basically a support for our pregnant women. We would serve as an insect repellent distribution area for our participants should that need become available. Also, those WIC clinics that are within health departments are encouraged to work closely with their health department in this type of planning so that everything can be best done for the patient and participant, whatever you want to call them, so that we can prevent this or make the outcomes as minimal as possible. So really, that's basically what we are, is we are support. We would serve as a distribution center for non-Medicaid WIC participants and possibly other pregnant women within the community, depending on how it's set up and what the plan is. WIC directors are encouraged to work with their health departments or their agencies that they're in to make sure they've got adequate space to store the insect repellent, adequate distribution areas, and how they would do this. So as soon as we're notified from ODH somewhere within the infection control or preparedness that there's an outbreak, we will be on it with our WIC staff to get them working with you all to get it to work.